Hi everybody, Dr Manny here. Welcome to Dr Manny's YouTube Learn Shops. This Learn Shop is about the generic or common disorders that may require intensive care nursing. This is part 1. Now the learning objectives for this session are to look at some of the common medical conditions that require intensive care and the signs and symptoms related to the specific medical conditions that are common or generic in most intensive care units. Now, the common medical conditions that I'm going to cover here today are respiratory failure, cardiac failure, shock, sepsis to a certain degree, diabetic ketoacidosis, stroke, and acute respiratory distress syndrome. Now, the first one is respiratory failure. Respiratory failure is just a medical condition in which your blood doesn't get enough oxygen. This is called hypoxia or hypoxemia. Or it's got too much carbon dioxide, which can be called hypercapnia or hypercarbia. Sometimes you can have both problems. Now the types of respiratory failure that typically are reviewed are type 1 and type 2. And type 1 respiratory failure deals with hypoxia, which is oxygen failure. And typically you've got a PaO2, or a partial pressure of arterial oxygen in the blood that's less than 60 millimeters of mercury, on a fairly high oxygen percentage of an oxygen of 60% or an FiO2 of 0.60. And this can be acute, which is in minutes to hours, or it can be chronic, several days, weeks, or months. Now, type 2 respiratory failure is hypercapnic or hypercarbic, and this is ventilatory failure. And this means you can't exhale the carbon dioxide effectively. And this results in a PaCO2 of greater than 45 millimeters of mercury, and a pH typically less than 7.35. If you're interested, have a look at the Dr Manny Learn shop on arterial blood gas interpretation. And with hypercapnic or hypercarbic type 2 respiratory failure, this can be acute, minutes to hours as well, or chronic, several days, weeks, months, even years longer. Now, the causes of respiratory failure with hypoxemic type 1, typically pulmonary edema, pneumonia, an acute lung injury of some kind, atelectasis, aspiration, pulmonary contusion, an acute pulmonary or pulmonary situations such as pneumonitis, pulmonary embolism, and there can be many others. Otherwise, can be related to type 2, hypercapnic, hypercarbic, where there's decreased pump function, the thoracic pump, and here increased load. So decreased pump function is a result of some sort of brain or spinal injury, CNS depression, a neuropathy of some kind, neuromuscular junction diseases, myopathies, or kyphoscoliosis. It can also be related to an increased load, chronic obstructive pulmonary disease, asthma, cystic fibrosis, and bronchiectasis, just to name a few. Now here's an example of pneumonia. This is a right middle lobe pneumonia. Have a look at the Dr Manny Learn shops on chest X-ray interpretation. They're simple, they're straightforward, and you'll probably learn a lot. Here's an example of congestive heart failure where you've got left ventricular enlargement. You've now got pulmonary venous congestion at the hilar. You've got pulmonary edema, which results in alveolar edema and increased infiltration. Foreign body airway obstruction can result in closure of the larger airways to the smaller airways, and as a consequence they can get atelectasis, which you can see in the left lung. Then here's an example of atelectasis, which you've got right upper lobe and middle lobe atelectasis infiltrating into the right lower lobe as well. Then you've got an example of acute respiratory distress syndrome, which basically means a white lung. Then you've got trauma. Have a look. You've got a fractured right clavicle, and you've got numerous fractured posterior ribs, first, second, third, fourth. The anterior ribs we can't see clearly, not on an AP film. Then you've got chronic obstructive pulmonary disease or airway disease, which results in hyperinflated lungs and broadened rib intercostal spaces. Typically, you get an elongated heart as well. Because remember, the heart is attached to the diaphragm. And with hyperinflated lungs, the diaphragm moves down. Then you've got scoliosis. Scoliosis means you've got mechanical problems. You can't inhale and exhale effectively. Cystic fibrosis, one of the chronic lung diseases. Tuberculosis, another fibrotic chronic lung disease. What are some of the signs and symptoms? Well, they can be neurological, which is to deal with restlessness, confusion, fatigue, headache, and you can even faint. Cardiovascular, which can be tachycardia, dysrhythmias, hypertension, and hypotension. Respiratory signs and symptoms could again be tachypnea, dyspnea, shortness of breath, wheezing, crackles on auscultation, and persistent coughing. The integumentary system, especially the skin, may be pale, blue, cyanosed, cool, clammy, with increased capillary refill time of more than 3 seconds. Cyanosed lips, demonstrating peripheral and central cyanosis. Cardiac failure is another condition, and cardiac failure is a chronic, progressive condition that affects the pumping of the myocardium, the heart muscles. It's also known as congestive heart failure, of which there are numerous. The heart muscle just doesn't pump well enough, as it should, and fails to meet metabolic requirements. You can have diastolic dysfunction, where the heart can't fill properly, or you can have systolic dysfunction, where the heart can't empty properly. Now, types of cardiac failure, broadly speaking, can be right-sided, left-sided, or a combination of both, congestive heart failure. In right-sided, you've got right ventricular failure, and this is where blood backs up to the body and you can get side effects that result in peripheral edema, which we'll mention briefly as we go through. Left heart failure, the heart can't pump blood out into the aorta, into the systemic circulation, which fails metabolic requirements. And congestive heart failure, a combination of both. So what are the consequences of cardiac failure? Well, with right heart failure, you can get congestion to the peripheral tissues, and this causes dependent edema, gastrointestinal, especially liver congestion, and it can cause anorexia, GI distress, and weight loss. But essentially, it results in what you can see as raised jugular venous pressure, ascites, an increased size in the abdomen, and you can see peripheral pitting edema. When you look at left heart failure, this is decreased cardiac output, which results in backflow as well, pulmonary congestion, impaired gas exchange, pulmonary edema, which can result in cyanosis, signs of hypoxemia, orthopnea, a cough with frothy sputum indicating that you have got pulmonary edema, and paroxysmal nocturnal dyspnea, which you get in the night time. You may or may not see an elevated JVP, unless, of course, it results in both right and left heart failure. You will see pulmonary edema. You will see cardiomegaly on chest X-ray. You will see pleural and pericardial effusions, and you may or may not see pitting edema unless you've got right heart failure. Now, with left ventricular failure, a good example would be to look at your chest X-ray. As I said, have a look at the Dr Manny Learn chops on chest X-ray interpretation. And with left ventricular failure on chest X-ray, you can see capillization of the pulmonary blood vessels, or vascular markings, which basically means you can see the veins on the X-ray, which normally you wouldn't see in the apices. You can see Curley's B lines, which indicate alveolar edema. You can see pleural effusions and sometimes even pericardial effusions. And you may see an increase in the cardiac-thoracic ratio, which in an adult should be less than 0.5. Then you've got right ventricular cardiac failure, which on chest X-ray you will see as pulmonary congestion, right and left atrial congestion, possibly right ventricular hypertrophy as well, and certainly cardiomegaly. With right ventricular cardiac failure, here's an example. You can see a raised jugular venous pressure, you can see ascites, and you can certainly see pitting edema. With congestive cardiac failure, you've got a combination. Biventricular failure, right and left. And what you actually see here on this chest X-ray is quite a large heart. Quite a large melon-shaped heart, indicating left and right ventricular cardiomegaly. Now, there are certain classifications, and I've just chosen the New York Heart Association functional classification for heart failure. Class 1, no limitations. You can do everything. Doesn't cause any signs and symptoms of your heart failure. Class 2, there's slight limitation with physical activity. You're comfortable at rest. Ordinary physical activity doesn't cause you too many problems. No issues. Class 3, problematic. Marked limitation in physical activity. You're still comfortable at rest, but less than ordinary activity causes symptoms. Shortness of breath, discomfort, fatigue, etc. Class 4, you've got severe limitations and discomfort with any physical activity. And sometimes even at rest. You can be doing absolutely nothing and become short of breath or be short of breath. What are some of the signs and symptoms of heart failure? Well, you're going to be distressed. So this activates your sympathetic nervous system. You can have dilated pupils. You can be anxious. You will certainly have shortness of breath on exertion, dyspnea. You can have orthopnea. You can't breathe unless you're sitting up. On auscultation, crackles, wheezes, as adventitious chest sounds. You can maybe coughing and cough up pink, frothy sputum, but it can be white as well. Your jugular veins will be distended with right heart failure. You may even have a myocardial infarction. You will be fatigued, weak, probably because of the decreased cardiac output which fails to meet metabolic requirements. Your blood pressure will be low, so you may be hypotensive, initially maybe even hypertensive. You can be nauseated and vomiting. You can have ascites, as I mentioned previously, and you can have dependent pitting edema, not only in the legs, but also in the sacrum, any dependent areas. If you auscultate, you may have a second or third heart sound. You can have an enlarged spleen and liver, splenomegaly, hepatomegaly. You can have decreased urine output, oliguria, and you may have a weak, rapid pulse with cold or cool, clammy skin as a result of sympathetic nervous system stimulation. Shock is another major medical emergency that occurs after serious injuries such as a motor vehicle accident. And this is one that patients are admitted to an intensive care unit. And it's a critical condition that's brought on by a sudden drop in blood flow through the body. You're hypotensive. The circulatory system fails to maintain adequate blood flow and the delivery of oxygen and nutrients to the vital organs. Now, types of shock, and I'm just giving you these as an example because there are many other sub-classifications which could be absolute or relative. Hypovolemic deals with hemorrhage and dehydration. Distributive deals with septic shock, allergic or anaphylactic, and a neurogenic situation. Cardiogenic can be congenital heart disease, congestive heart disease, can be myocarditis, dysrhythmias and arrhythmias such as ventricular tachycardia, or you can have myocardial ischemia or infarction. Then you've got obstructive, which can be cardiac tamponade, pneumothorax, which can be tension, a pulmonary embolism. Hypovolemic shock, loss of blood, loss of circulating blood volume. Distributive shock, neurogenic, head injury, spinal cord injury. Even related to medications that block neuromuscular transmission, neuromuscular blocking agents, overdose. Distributive can also be allergic or anaphylactic reactions. Distributive shock can also be septicemia, septic shock. Then you've got cardiogenic shock, which deals with the heart. You've got obstructive shock, which can be pericardial tamponade or an effusion. Pericardial tamponade being acute, effusion being chronic. Obstructive shock can also be a pneumothorax, especially a tension pneumothorax. Obstructive shock can also be a pulmonary embolism, but it would be a massive pulmonary embolism. Let's say obstructing, in this situation, the circulation to the right lung. What are the stages of shock? Now, these are just typical. Stages of shock can be compensated, which means the systolic blood pressure is more than 90 millimeters of mercury in an adult, and essentially it's normal, but you've got all the signs of poor tissue perfusion. Cold, pale, clammy, skin. Stage 2 is progressive, and this is also referred to as decompensated shock. And you've still got all the signs of decreased tissue perfusion, but your compensatory mechanisms have failed. Your systemic circulation is getting exhausted. And this results in systolic hypotension, less than 90 millimeters of mercury in an adult. Stage 3 is irreversible, where there's a progressive decline in the blood pressure and tissue perfusion with organ failure until death occurs. The consequences of shock you can review here. Essentially, hypovolemic. The consequences are you'll be anxious, thirsty, weak, confused. You may even have syncopal fainting attacks. You'll have a tachycardia, hypotension, increased respiratory rate, with cold, pale, clammy skin. Then you've got distributive, which is a combination of anaphylactic, neurogenic, and septic. And when I say combination, I don't mean that they're all combined. However, they could be. Septic is essentially resulting in a bounding pulse with altered level of consciousness, tachycardia, hypotension, and tachypnea. Neurogenic, paralysis distal to the injury site. It can also result in tachycardia or bradycardia. Bradycardia typically because of sympathetic disruption. Hypotension and tachypnea. And your skin won't be cool and clammy. It will typically be warm and flushed and dry. When it comes to anaphylactic, well, it depends. This is a severe allergic reaction, and you may see a rash, urticaria, you may have itchy skin, decreased level of consciousness, and maybe breathing difficulties as a result of bronchoconstriction. You'll have a tachypnea, you'll have a tachycardia, and you will be hypotensive in the severest form, anaphylaxis. Then you've got obstructive. Obstructive is anything that obstructs the great vessels of the heart, the aorta, pulmonary artery. So pulmonary artery, pulmonary embolism. Aorta, cardiac output. We're talking about cardiac tamponade, tension pneumothorax. And if you listen, you will hear muffled heart sounds, S1, S2. JVP will be elevated, decreased level of consciousness, poor signs of tissue perfusion. Tachycardia, hypotension, and tachypnea. These are some of the consequences of shock. When we review diabetic ketoacidosis, that's another serious complication related to diabetes mellitus type 1, and that occurs when your body produces high levels of blood acids called ketones. The The condition develops when your body can't produce enough insulin, and without insulin, the body begins to break down fat as fuel, which results in the production of ketones. Ketones are essentially a byproduct of your body burning fat for fuel. If you don't have enough insulin and you're experiencing prolonged high blood glucose levels in the body, fat will eventually be broken down. Eventually, muscle will be broken down as well. And this will cause ketones to build up in your blood, making the blood acidemic as a result of an acidosis. What are some of the precipitating factors for diabetic ketoacidosis? Certain medications, infections, an insulin deficit. Endocrine could be as a result of Cushing's disease. Cardiovascular, stroke, myocardial infarction, any stressful event. Other stressful events could involve pregnancy, pancreatitis, psychological distress, shock, or even trauma. What are the consequences of diabetic ketoacidosis? Well, the early signs are that you're thirsty, you're polyuric, you're hypoglycemic, you're hyperketonuric. Later, extreme signs, you're fatigued, you're feeling sleepy, you've got dry, flushed skin, you're nauseated, you've got abdominal pain, which they're not exactly sure why occurs, but probably related to the ketone acids. There's difficulty in breathing, and you may, as a healthcare provider, smell an acetone breath on your victim, fruity smelling breath. Ketone bodies produce a sweet scent. What are some of the clinical signs and symptoms of diabetic ketoacidosis? Well, central nervous system, altered mental function or mentation is affected. You can be weak, confused, stuporosed, or even in a coma. The cardiovascular system, you're dry, so you're dehydrated. You're hypotensive. Tachycardic, you've got decreased tissue perfusion. You can have Cushing's respirations, which are rapid and deep, with a fruity breath in the respiratory system. In the renal system, you'll be polyuric with ketonuria. And look, glycosuria as well. In the gastrointestinal system, polydipsia, you're thirsty, nausea, vomiting, and abdominal pain, as I mentioned previously. Other indications can be hypokalemia, hypoglycemia, and a metabolic acidosis on arterial or venous blood gas analysis. What are some of the helpful acronyms for diabetic ketoacidosis? Well, the signs and symptoms: D, diuresis, polyuria, dizziness, dehydration, delirium, drinking a lot, and you're polydipsic, so you're thirsty. K, Cushing's respirations. They basically attempt to correct the metabolic acidosis by making you breathe faster and deeper. A, abdominal pain and vomiting. What's the diagnosis? Diagnosis will be done on capillary blood glucose, which is typically greater than 14 millimoles per litre. You can have ketonuria, so you're ketotic, K, greater than 3 plus. You're acidemic or acidotic, pH is less than 7.3, with a bicarbonate, serum bicarbonate, of less than 15 millimoles per litre. A stroke is another condition that can have a patient admitted to an intensive care unit. Now, a stroke is essentially a brain attack in lay terminology, just like a myocardial infarction is a heart attack. A stroke occurs when blood flow to an area of the brain is interrupted, and when this happens, the brain cells are deprived of oxygen, anoxia, and they begin to die. You can have two types of stroke, generally speaking: an ischemic stroke, which is obstructive, or a hemorrhagic stroke, which releases blood into the brain tissue area. Ischemic stroke, obstruction, hemorrhagic, blood escapes from the blood vessel. Both can result in brain tissue damage. Looking at it a little bit more closely, we can see types of stroke being ischemic, obstruction within a blood vessel supplying blood to the brain, hemorrhagic, when a weakened blood vessel ruptures, releasing blood into the surrounding tissue, transient ischemic attack, which is where you've got an obstruction caused temporarily by a clot, often called a mini-stroke. Now, you've got numerous types of stroke risk scores. I've just chosen this one to demonstrate one that's available. Risk factors, blood pressure. You can have high, cautionary, or low risk. Atrial fibrillation. This results in the formation of clots in the heart, which can cause an obstructive stroke. Smoking, high cholesterol, diabetes mellitus, lack of exercise, incorrect diet, a history of stroke in the family, and you can evaluate to tell you whether you're at high risk, cautionary, or low risk. I'll leave it up just for a little while longer, just in case you want to evaluate your risk of stroke. When I look at mine, my blood pressure is okay. I don't have atrial fibrillation. I'm a non-smoker. My cholesterol is less than 200. I don't have diabetes mellitus. I try and do regular exercise. I try and have a healthy diet, and my weight is quite healthy. And I have no history of stroke in the family. Well, I have no risk of stroke in the family, and my total score would be one of low risk. What are 5 signs and symptoms of stroke? Well, sudden difficulty in walking or dizziness, loss of balance. A severe headache for which there's no cause that you know of. Sudden visual problems in one or both eyes. Sudden numbness or weakness in the face, arm, or a leg, or all. Sudden confusion or trouble speaking or understanding speech. An acronym: FAST, face, drooping, arms, not coordinated, speech, slurred. Make sure you call your emergency response system quickly. Another acronym can be BFAST. Think of balance, coordination, eyes, blurred vision, face, arm, speech, and time being important. ARDS syndrome, acute respiratory distress syndrome. Another reason patients can be admitted to the intensive care. Often they're already in intensive care before the syndrome really has an effect. It's a progressive syndrome that typically occurs in critically ill patients. It causes an acute lung injury damaging the alveolar capillary interface. It increases pulmonary capillary permeability, therefore fluid leaks out of blood vessels and into the alveoli, increasing alveolar fluid. It's typified by non-cardiogenic pulmonary edema, respiratory distress, and refractory hypoxemia, which basically means this pulmonary edema is not caused by the heart failure. It causes respiratory distress, and regardless of what you do, the patient remains hypoxic. What are some of the direct causes? Pneumonia, pneumonitis as a result of gastric contents aspiration, less common, pulmonary contusion, fat emboli, near drowning, whether it's fresh or salt water, inhalational injuries such as smoke, burns, or chemicals, reperfusion injury, post-lung transplantation. And this can even occur post-cardiac surgery because you've been on cardiopulmonary bypass. Then you've got indirect causes such as sepsis or shock states, and the less common, as I mentioned, cardiopulmonary bypass, drug overdose, acute pancreatitis, and multiple blood product transfusions. Clinical signs and symptoms can be early and late. The clinical signs and symptoms depend on the cause, of course, but if you get them early, less than 48 hours, patients with ARDS are restless, confused, level of consciousness changes. They can be fatigued, short of breath, be hypotensive. They can have a cough. They can have fever. Typically here that occurs though in situations of sepsis. Chest X-ray is typically normal. More than 48 hours, breathing becomes laboured. There's dyspnea, tachycardia, cyanosis, thick froth in sputum. They will be in a metabolic acidosis and probably a respiratory acidosis as well. There'll be pulmonary crackles on auscultation, and there'll be a decreased PaO2 and an increased PaCO2. They'll be hypoxemic and hypercarbic. The chest X-ray will change and it will be quite abnormal. What are some of the complications of ARDS? A greater risk of hospital-acquired infections, nosocomial, ventilator-acquired pneumonias because they're on a ventilator, barotrauma such as pneumothorax, deep vein thrombosis, pulmonary emboli, renal failure, sepsis, disseminated intravascular coagulation, coagulopathies, DICC, pulmonary fibrosis and scarring. So in summary, an ICU specialises in providing care for specific health conditions or injuries which include major trauma, severe burns, which we haven't really covered, respiratory failure, cardiothoracic surgery, look at the cardiothoracic surgery learn shop, organ transplants, complex spinal surgery, and care must be provided by you as a competent healthcare provider, nurse with critical thinking skills. Let's review briefly. Here's a review activity. Name 2 types of respiratory failure. They are type 1, hypoxemic, and type 2, hypercarbic or hypercapnic. Name the causes of respiratory failure in the following diagram. For hypoxemia, type 1, hypercapnic, type 2. Hypoxemic, pulmonary edema, pneumonia, acute lung injury, atelectasis, aspiration pneumonitis, pulmonary contusion, acute pneumonitis, pulmonary embolism, and numerous others. Hypercapnic, CNS depression, brainstem injury, spinal cord injury, neuropathy, neuromuscular junction disease, myopathies, kyphoscoliosis, chronic obstructive pulmonary disease, asthma, cystic fibrosis, bronchiectasis. Reflect on the signs and symptoms of heart failure. What are they? Remembering. You've got sympathetic stimulation, which can result in the following: dilated pupils, pale cold skin, dyspnea, orthopnea, auscultation, crackles and wheezes, cough, a pink frothy sputum, decreased blood pressure, so they're hypotensive, nausea and vomiting, ascites, dependent pitting edema. You've also got anxiety with restlessness, hypoxia with falling SpO2s, saturations, confusion, jugular vein distension, myocardial ischemia, infarction, fatigue, an S3, S4 gallop, tachycardia, indicating heart failure, an enlarged spleen and liver, decreased urine output, oliguria, maybe even anuria, and weak pulses. Name 4 generic types of shock. They are hypovolemic, distributive, cardiogenic, and obstructive. Hypovolemic being hemorrhage and dehydration, distributive being septic, anaphylactic, and neurogenic, cardiogenic being congestive heart failure, congenital heart disease, myocarditis, certain arrhythmias such as ventricular tachycardia, myocardial ischemia and infarction, unstable angina, obstructive pericardial tamponade, tension pneumothorax, pulmonary embolism. Name 4 early and 4 late signs and symptoms of diabetic ketoacidosis. They are early, feeling very thirsty, polyuria, urinating often, hypoglycemia, high blood glucose levels, hyperketonuria, high ketone levels in the urine. Late, feeling extremely weak and fatigued, constantly sleepy, flushed dry skin, nausea and vomiting, abdominal pain, difficulty in breathing, shortness of breath, acetone, fruity, smelling breath. Name the 6 components of the BFAST acronym to determine stroke. They are B for balance, loss of coordination, a headache or dizziness, eyes, blurred vision, E, face, facial drooping, arms, arm or leg weakness or drift, speech is difficult to understand or perform, time, you don't have much time, call your emergency medical system. State 4 clinical signs of the early stages of ARDS. Restlessness, confusion, level of consciousness changes, fatigue, shortness of breath, hypotension, a cough or a fever, depending on whether there's an infection. The chest x-ray in the early stages is typically normal. Clinically, a person with ARDS gets sick first, the chest x-ray gets sick second. State 4 clinical signs and symptoms of later stages of ARDS. Laboured breathing, dyspnea, tachycardia, cyanosis, frothy sputum, metabolic and respiratory acidosis, pulmonary crackles and wheezes, decreased PaO2, increased PaCO2. The chest x-ray will be abnormal. The chest x-ray gets sicker in the later stages. Okay, thanks a lot. Check out other Dr. Manny Learn shops, but most importantly, follow through with this one and look at the management of disorders requiring intensive care in part 2 of this Learn shop. See you again next time, and please, if you think this is of any value to you, please recommend it to your colleagues. And look, why not subscribe? Ask if there are any things that you would like to be covered. Cheers for now. See you.